What is up, Sleep Tribe? Welcome to a brand new episode of the Healthy Sleep Revolution podcast. Today, I have a new friend. I have Dr. Shelby Harris, who, by the way, I have been stalking on Instagram. So if you guys aren't following her on Instagram, go follow her. We'll post her Instagram handle and all of that fun stuff in the show notes. But there's so many questions I have, and I know so much that we're all going to learn from her. So I'm just going to go in and get going. Good morning. How are you doing?
Oh, I'm really good. Thanks. Thanks for having me. I appreciate it.
Oh, it's such a pleasure. So you are a clinical psychologist and also a sleep specialist. Is that right?
Yes.
Where did these two intersect? She's smiling at me. She's like, I get this question all the time. How did this come about? Tell us a little bit more.
So there aren't many of us out there. So when I knew for a long time I wanted to go into psychology. I was also a music major in college. I did both music and psych, and I really knew I wanted to do psych for a while. And I was put on a research study that looked at insomnia and treating insomnia in people who were in early recovery in rehab from alcohol issues, because we found that if you treat their insomnia early on. And at the time we were using a medication called trazodone, so a long time ago, we found that it actually reduced relapse rates. Because a lot of people go back to alcohol because they're not sleeping. So we found if we treat the insomnia early on, it made a big difference. And that just made a light bulb go off in my head. And I said, you know what, there's something to this. Why are we not talking about sleep more? And we're talking like 2000, like it was even before then. It was really something that we weren't addressing. And so when I went to graduate school for psychology, I looked for, and it was very hard to find, I looked for people who did insomnia work or sleep work. So I went to a graduate school at Yeshiva University where my mentor at the time, did insomnia and nightmare work. And I was able to then be in the Mount of Fear system and work at the sleep lab and kind of carved out this niche and got trained by neurologists and psychologists that I really have a really good background in sleep medicine as well as psychology.
Wow, so fascinating. Was it hard to kind of put yourself out there, not because of lack of confidence, just because there's nobody else doing this? Did people look at you like, are you crazy? What are you talking about? Or they were like, oh my gosh, where have you been all our life?
It was, they had done a little bit of cognitive behavior therapy for insomnia. There was one main book that was out by SB, but there really wasn't that much. And so people were like, oh, it's such a manualized approach. We have to treat the depression and anxiety first, which has now since been debunked. That some people thought I was just like kind of looking for, I don't know, they thought I was shooting for the stars, but I wasn't really going to get anywhere. But when I got to the sleep lab, when I was an intern at Montefiore, I asked one of my advisors, like, can I just work in the sleep lab a little bit? The director of the sleep lab, Michael Thorpe, was amazing. And he really took me under his wing. And that's where I felt like I found my place, because I found all these patients that were like, I've treated my anxiety, I've treated my depression, and I'm still not sleeping. What do I do? So that's really where I got my training, and it felt like it was a home. And since then, a lot of other people have started to come around, and they're like now referring to me all the time and asking me to, talk with them and train them. So it's really wonderful to see the turnaround.
That is so amazing. Trailblazer right there. So let's get into what is behavioral sleep medicine? We're talking to, as you said, there's not too many of you that do this. And you're certainly my first guest on the show that we're even scratching the surface. So what is behavioral sleep medicine? Does it help? Well, of course it does, because you're here. And how? There's
a little bit of a misconception of what behavioral sleep medicine is versus people who do CBT, so cognitive behavior therapy for insomnia. So there's more and more people who are doing these trainings, which are wonderful, in CBT for insomnia. So they really are learning how to deal with just insomnia issues. And I think there's definitely a need. There's a lot of clinicians who are in practice who see all these other issues, and they have a lot of people who have insomnia. So learning how to do that one treatment is wonderful. What behavioral sleep medicine is, though, and the people who are board certified in it, they go beyond just insomnia. And it's all using evidence-based treatments to help without medication to help sleep problems. So I worked when I was in the sleep center, and now just in private practice, I worked with insomnia patients, people who were extreme night owls, could sleep a full night, but just on a very different schedule. And we worked using light therapy, melatonin, timing of their sleep problems. I did a lot of people who have apnea and couldn't use their PAP mask, doing a lot of work on motivational interviewing and claustrophobia insomnia work and couples work. I worked with babies through older adults. So I did a lot of parent training for babies who are having trouble sleeping, narcolepsy, excessive sleepiness issues. Otherwise, I mean, there's a place for behavioral treatments in almost all sleep disorders. So it's really complementing the MDs to really get the most out of the treatment.
As I'm understanding this, it is still a team approach. You're still working with your sleep MDs, with whoever else makes up their sleep team, and to help these patients. How does treatment or therapy differ of course it differs, but for the younger population, talking to our parents here versus someone like me, what or how would you approach things?
Yeah, I think some of it's the same, some of it's different. It depends on the issue, right? Let's just say it's a sleep issue when it comes to insomnia. So when it's with young kids, preschool babies, that's when it's a lot of parent training about proper wind down routines, timing sleep properly, right? Some people are just totally not getting their kid to bed on the right time, that they're almost always overtired, the importance of naps, and learning how to have your child be able to sleep well without needing a lot of crutches to be able to sleep. So it's parent training. Then when you get into the school age kind of kids, then it's parent training, but it's also working with the children to help them understand good sleep habits, timing of sleep properly, any of the sort of like anxiety management. I'm not a child psychologist per se, but a lot of it's working on just the nighttime behaviors as well as working with the parents on helping with sleep. And then adolescence is a whole other issue, right? So adolescence, there's a lot of night owl syndrome, struggle getting up in the morning. So, and I always say, like with the older adolescents, they've got to learn to do these things themselves. So I'm not working with the parents as much because these kids are often going to college and they're going to have to learn to survive and figure out how to get up earlier. So we'll do that. And then with adults, it's a lot more tailoring bedtimes, wake times, worry journals, all that sort of stuff too.
Perfect. So our parents can start with their infants. We don't have to.
Yeah.
We don't have to wait until they're a certain age or, they can follow directions or any such thing.
Nope. It just varies. If there's a problem, you should address it. And the earlier you address it, the better.
That is perfect. Do you work with wearables at all? Do you encourage use of like an Oura ring or any such thing? Where does that fit into the realm of how you help?
I don't use them routinely, and because I'm best known for insomnia work and with people who tend to have a lot of anxiety that fits into the insomnia, I find the wearables sometimes actually worsen the insomnia for a lot of people. So they become very fixated on, well, I didn't get this much sleep, but so it actually there's a hyper focus on it. We call it orthosomnia. My colleague Kelly Glazer Barron started that term, and it has caught on because it really does. I see that in some patients. That being said, I do use, like a lot of patients in New York are wearing Oura rings, or people are wearing Oura rings. I do use those things for tracking sleep-wake patterns, not necessarily sleep staging, REM sleep, deep sleep, light sleep. But if I have someone that I think has a circadian delay, they're a night owl, or they're kind of on and off throughout the day, or sometimes even an older adult who might be sleeping a lot during the day, it gives me ideas as to their sleep patterns overall. But for insomnia patients, I don't use it all that much.
I want to jump into your book because a lot of your work is with women and insomnia. So for those that are listening in, she has an amazing book called The Women's Guide to Overcoming Insomnia. And you talk about getting a good night's sleep without medication. I talk a lot about, and it comes down to, even when I see patients in my practice, it's not uncommon for moms to come in and say, almost like a badge of like they're proud. Oh, I have to give my kid like 2 of those gummies or 3 of those gummies to help them fall asleep. And you and I both know that isn't always the answer. Talk to us a little bit about how this I'm fascinated with the without medication. Tell us more.
Okay, so it's geared towards people with insomnia. So what's insomnia? Trouble falling asleep, staying asleep, awakening too early. And it has to create a problem somehow for you, right? So are you annoyed by it? Do you feel you're tired during the day? You're having memory issues? What is the problem that it's creating? And in the field of sleep medicine, and actually in primary care guidelines, and even the recent menopause guidelines from NAMS, the gold standard treatment should be cognitive behavior therapy for insomnia. So a non-medication approach first, because we find in so many research studies by now that it works just as well as most medications, and if not better in the long run. Usually people, when they stop taking sleep meds, they start having sleep problems again because they haven't learned certain tools to be able to continue to sleep well. So what we try to do in my book is all about that, is really treat people using cognitive behavior therapy. So changing the timing of your bedtime, wake time. Sometimes it goes against common sense. I have people spend less time in bed, what they do at night. A lot of people try to force sleep or lay still or toss and turn, try to change some of those behaviors. We change the basic sleep hygiene. It's not just sleep hygiene. So it's not just like limiting caffeine and alcohol. That's a piece of it, but that's not at all the entire thing. And then for some people, we need to work more on their worries about sleep, like the forcing sleep to happen, or worries about what will happen if I don't sleep. And we teach people to challenge those thoughts or to learn to do meditation to let those thoughts go. And it's a very short-term treatment. I have some patients that do better in just 2 sessions, but usually 4 to 12 sessions, depending on the complexity and if they're on medications, is kind of the standard. And it works just as well for many people as medication, but it's not for everyone. So we always try, in like a triage kind of approach, we always try to treat people using non-medication approaches because that's the safest in the long term. And then if that's not enough, then we start thinking about combining behavioral treatments with medication so you can be on the lowest dose possible to sleep better. So, and if that doesn't work, then we go to other things that might not have been studied as much. Or we look at like airway health. We look at any apnea or any other things that could be impacting their insomnia. So there's a lot of different things we can do. We just try to start with the least amount of medication possible.
Yeah, that makes so much sense. Again, like I said, it's fascinating to find a doctor that doesn't want to just give me a prescription.
Yeah.
Like, here's a drug, take it, and I'm sure it'll help, but let's try something else first. Again, focusing on the women again, does your protocol or does anything have to change with your perimenopausal, menopausal women? What does that look like?
I think the women aspect in the book, it was really focused because people, it's so funny. I wrote the book, came out in 2019 before like all the stuff with menopause, like this whole revolution's come out, which is amazing. And I love it. But I wrote it really because people didn't appreciate the hormonal changes that can impact sleep, or a lot of women just kind of accept and say, you know what, or their physicians have told them like, this is kind of what it's going to be like. Good luck. So even starting with adolescents and younger women, having your menstruation every month for some women, even right before they menstruate, they have insomnia issues. So learning to track that to see where you might be able to make some changes. Pregnancy, postpartum, what are some changes you can make? It might not be perfect, but there are probably things you can do to help improve it a little bit. And then when it comes to perimenopause and menopause, which we see all the time, we try CBT for insomnia first for many people. But if that's not enough, then we think about hormone therapy. We think about certain supplements. We think about, it's a whole interdisciplinary approach that you have to think about to really get at the root of it for a lot of people.
Yeah, this is fascinating because I have 2 teenage girls, and my older daughter, literally, this was our conversation last night, and she was up. I heard the door slam and I was, okay, what's wrong? Is somebody sick? What happened? And she's like, I just can't sleep. We got into this whole talk about, well, I do think it has to do with my cycle, starting in a day or so. I was like, oh, it's fascinating that you mentioned this. So of course I know to look more into this for her as well. How long is long enough before we consider, like you mentioned, HRT for menopausal women? How much of a time frame do you give before you say we need more?
Yeah. I usually tell people like, give it like a good 2 months of trying really routine behavioral changes. And if that is not enough, that's when you really want to talk with your doctor about other things. Like you should start to see gains in 1 to 2 months. And with behavioral stuff, and if you haven't started to see any gains, or you just are like suffering, you've been going on for 2-3 months now of just having poor sleep, even if you don't even know what to try first, that's why you should talk to your doctor about it.
And then are women with upper airway resistance syndrome, which we see a lot, and or apnea, where would CBT and all of this fit into with actual treatment and therapy? When would you recommend we bring you in along with whatever, say an oral appliance or other treatment that they may be needing?
It's so tricky. Like we call it COMISA, right? Comorbid. So you have both insomnia and sleep apnea or upper airway, whatever might be going on. And I see it all the time in my patients, right? So if someone comes to me and they are reporting any symptoms that I think might be indicative of needing a sleep study and needing further intervention, I'll refer them to that for treatment. But that being said, it takes so long for some patients to get a study or to talk with a physician that it's easier to start with just some of the behavioral stuff first. So I'll start doing some of those things, but I will always caution the patient, that sometimes you might find that you're falling asleep faster, you're staying asleep more, but you still might feel when you wake up very fatigued or sleepy because the quality of the sleep hasn't improved because of any breathing issues that might be happening. So we work together all the time. It's just still a little bit of a debate in the field as to what treatment you start first. And I'm just
first the chicken or the egg.
I'm just practical. Like when I was at the sleep center, patients could get in with me or an MD, but then they still had to wait 2 months for a sleep study. So why are we withholding any treatment when we can do some things? It's just kind of, you do everything, you just have to time it out based on practicality.
Right. And also the flip side too, hey, you're starting to feel a little better. Don't not go get your sleep study.
Oh yeah, for sure.
And yeah. Let's talk about sleep training. I was, looking at all of the fascinating work that you have out there. Can it truly be harmful for children, sleep training? There's the myth out there. It's like, oh, if I'm going to let my child, I don't know, cry it out or whatever, I'm scoring them for life. Tell me more about that.
There is no data that shows that it does any detrimental or harm or any issue to children. What we do see is that letting a child continue to have sleep problems can cause bigger issues down the road. I mean, I can't tell you how many kids I have seen over the years who are 8, 9, 10, even 12 or 13, who still need their parents in there in the morning when they wake up early to help them go back to sleep. And the busiest time of year when I get like child referrals is always before the summer for me, because their kids are going to go to sleepaway camp and their parents are worried, how are they going to be able to sleep in their sleepaway camp? It doesn't usually resolve itself as they get older. So sleep training has no negative repercussions and only benefits them in the long run.
Yeah, I certainly agree with that. As a dentist that focuses a lot on sleep apnea treatment for adults and children, I personally, within the practice, we saw more people become aware and actually seek help during the pandemic. Did you notice that as well?
Yeah, I definitely saw that.
Yeah. And did you feel like was there a shift in what you noticed or how all sleep patterns and everything impacted our patients and the population in general because of that?
I mean, I have so many thoughts on what the pandemic did. I mean, there are some patients of mine who actually got better at the beginning of the pandemic because they didn't have to get up at the same time every morning, go to work at the exact same time. They had less stress about, because I work in New York City, that there are a lot of people who they wake up too early because they're anxious about missing the train and then commuting in and all that stuff, that stress was reduced for them. So they actually felt better and slept better. Other people, they had a major shift in sleep patterns. So would go to bed a lot later, sleep a lot later. Some people actually found that was better for them. But what I saw a lot of was just a lot of people had more insomnia because rates of anxiety and depression went up. But we also find that there was less light exposure for a long time. People weren't moving. They were sitting, as a lot of us do, sit at our computers all day long. Those basic, and the structure was lost. So that's like a recipe for disaster. And then what I also saw a lot of, and I totally appreciate why, was a lot more of like typical benzodiazepine use. So a lot of patients were put on Xanax, clonazepam. I still see people being put on Valium, because they were just so anxious and not sleeping and anxious just about the pandemic. But then they all started coming to me after about 6 months to a year because their doctors didn't want to prescribe the medication anymore. So they needed to learn other ways to sleep better.
We traded one problem for another, didn't we?
Exactly.
Yeah. So coming back to our teens, right? Like I said, I have 2 teenage girls and it drives me bonkers that school starts so early in the morning and it almost seems like they never get enough rest. Yeah. Never. They're either up doing homework or can't sleep and still have to wake up in the morning. And I know some of this comes with the sleep cycle shifts in our teenagers. Can you touch a little bit on that?
So what naturally happens as younger children, school-age children, become teenagers, and it can happen as 11, 12, 13, that age range, as early as that, and people don't even realize that that can start, is that there's a natural shift in sleep-wake timing. So they go from being early birds, which is a lot of parents complain about, right? Oh, my kid's waking up at 5 a.m. They shift to going to bed later, a lot later, and then wake up later. And that's a totally natural thing. It's biologically driven. That being said, there's some kids who overshoot the mark too far. And even with a later school bedtime, they struggle to get up. And those are the ones that end up in my office treating a sleep disorder. But the problem in our society is that school start times for middle school and high school are often way too early, that we're asking our kids to get up essentially in the middle of the night for them, and then ask them to take their biggest tests in the morning when they're half asleep. And we see higher risks of car accidents and injuries and school athletic injuries, all because they're so sleep deprived.
So it's not just them staying up on TikTok or Netflix or Snapchat. It's a combination.
It's a combination. It's a piece of it. So like I have a just about 13-year-old son that over the past year started to go to bed later. And he sometimes goes to bed later than me. But I still have limits on stuff. But I've just changed them to be later, because I know even if I try to get him to go to bed earlier, there's no way he's going to fall asleep at the same time as me because of his biology. So I still have limits set for his phone turning off at a certain time, for any video games turning off at a certain time. And I say, I want you up in your bedroom. You can do whatever, you can read, I don't care, but just without a screen for a half hour before bed so you can wind down. So still being able to set those guidelines without policing everything is helpful. But the other thing I do encourage parents to do, if you're in a town that has a really early school start time, is to really work on advocacy and really trying to work at getting your school system to change. And there's a huge, like California has now got the law that they have to start at 8:30. I was able to work with our superintendent. I have a tiny town that I live in. We were able 2 years ago to change our school start times. It's not easy everywhere, and no one is going to be, you're not going to make everyone happy, but there's great programs like Start School Later that you can go to online that have advocacy information, that you really have to start like a grassroots effort to kind of get them to understand and change what's been done.
Yeah, it's an uphill battle for sure. I mean, you think about it, let the younger kids go to school early, right? Yeah. They are anyways up at the crack of dawn, ready to get going. So for sure.
And a lot of people in my town were concerned about a lot of logistical things in the afternoons because the younger kids get out earlier. Who's going to take care of them? And I get that. But the reality is it's been 2 years now. People figure it out. And now our younger kids start earlier. The older kids start at 8:35. And that's just how it's done. And it's much, much better.
Yeah, for sure. Because like you mentioned earlier, with these teenagers that are tired, and new driver, right? 2 girls here that are getting their licenses. I worry about them being on the road and not fully awake. My kids don't drink coffee. I don't encourage, it's like, let's wake up actually rested. So I completely get it. That is great information and a great resource. We'll post those in our show notes for our listeners. I also see that in addition to CBT, you are specialized in DBT. Mm-hmm. What is that? And tell us more about it.
Well, I do DBT. I don't do it as much in a formal way as I used to, but I was trained in it in my fellowship. So it's called dialectic behavior therapy. And it's really about it's a very skills-based treatment. So it works on people who have a lot of anxiety, a lot of depression, bipolar disorder, borderline personality. We use it, eating disorders. We use it in so many different areas, but there's skills, whether it's emotion regulation, interpersonal skills, mindfulness skills that you work on. And it traditionally has a group aspect as well as individual therapy. But a lot of people have started to kind of take pieces of DBT and use it in an informed way in their practice. And that's what I do nowadays with some of my patients. So I use a lot of mindfulness therapy with my patients. I do a lot of ways to kind of regulate emotions in the evening. If you feel that you're very anxious or upset or depressed at night, ways to self-soothe, all those sorts of things. So we use a lot of those strategies kind of in our own treatment, but the DBT is an amazing intensive treatment. And if you're looking for DBT, make sure you find someone who is very well trained in it and does it as it should be.
That is fascinating, because literally 30 minutes before I got on this call with you, I was speaking with somebody who said they're having a hard time helping their 6-year-old down-regulate at the end of the day because, and she said, well, I've seen other children that come home tired, exhausted, have a meltdown that lasts for maybe 20 minutes. Yeah. My daughter, it goes on for an hour and a half. Yeah. How or what? So this certainly sounds like they need to contact you.
It's a little different. DBT is a little bit different than that. But in 6-year-olds, like they kind of modify and do different things. DBT is a little bit older, but it's all like similar strategies that you would do. And
Yeah. Wow, that's fascinating. And I know we touched briefly upon it, but what are some of the other sleep issues or disorders that you help your patients with? And what does that typically entail?
Oh, it really varies, which is kind of what I love about my job, is I get to see all different types of sleep disorders. So the most common things I see, most common is insomnia. Then I see a lot of circadian delay patients. So it's different than insomnia in that if they're allowed to sleep on their own schedule, they'll sleep a full night typically. So I see a lot of people who go to bed at 4 a.m. and wake up at noon, or try to wake up at noon, or they have to get up early for a job and then they're chronically sleep deprived. And those treatments will entail light therapy. They're all very personalized to the patient. So it's specific light therapy timing. Sometimes that's where we use melatonin a lot in low doses for circadian rhythms to help set your body rhythm. Timing of sleep, I'll change. I work a lot with the patients who have narcolepsy or excessive sleepiness issues. I've been doing that for years since I was at Montefiore. And that can be anything from psychosocial support, helping to educate families, employers, because a lot of people don't understand narcolepsy, and working on behavior strategies like napping strategies, coping strategies, exercise, diet, all that sort of stuff that can also influence sleepiness and energy. I'll work with people, like I said, who have apnea, who just can't get used to their PAP if they have to use a PAP, sometimes oral appliance, but mostly it's PAP. So working on treatments for that. And then babies, kids. I mean, it really varies. There's so many different areas that I can touch upon.
That's amazing. What have I not asked you that you think our listeners would benefit from knowing or learning?
I think that the one thing that I say in almost every interview is that you are the expert in you. And if you think that something is off with your sleep, if you are a thin, young, athletic woman, right? If you feel that you're not just tired because of living in a pandemic and being your age, if you feel like something is off, if you feel like the sleep you're getting isn't refreshing, if you feel like just because you're going through perimenopause that this is what's going to happen and no one's listening to you, find a doctor who will listen and not just dismiss it. Because the sleep issues get dismissed so frequently in our society because of the power through idea that I want more people to speak up for themselves and advocate for themselves, to find doctors who will listen and understand.
Yeah, for sure. I say the same. It's if you know your child, you know yourself better than you. If you're not happy with the answers, get a second, third, fourth opinion. Don't rest until you have an answer, because there's always an answer, is there not? There's always going to be somebody that's going to be able to help you or guide you through this.
Yeah. And then the one other thing I add too is that there are a lot of people out there who say that they treat insomnia, but they really just do sleep hygiene, which is not really well training. So if you're looking for treatment, really go to like reputable associations like the Society of Behavioral Sleep Medicine or ADSM. Like, you want to go to places where you're getting people who are legitimately trained in that area, not just like a weekend course, who know what they're doing, because that's going to be a really good first step for a lot of people.
Great information. How do our listeners find you, work with you, follow you?
So a bunch of different ways. So easiest is to go on to my website, drshelbyharris.com. And then you can also go on my Instagram. So it's at sleep.shelby. I'm also on TikTok a little bit. I'm starting that a little bit more at sleep.shelby as well. And you can write to me through any of those means and get more information.
Perfect. We will have all of Dr. Harris's information in the show notes. So like I mentioned at the start of the episode, go follow her Instagram. She has some amazing content out there, her website as well. And I do believe everybody needs a copy of her book on their bookshelf. Thank you so much for spending time with us this morning and sharing all of this. I'm still mind blown. I know I'm going to be texting you with more like, so what do we do about this? Or watch out for Instagram messages.
Anytime. Thank you for having me. I really appreciate the discussion.